This video is going to be on selective hypoalbuminemia, which means that albumin is decreased without a proportionate decrease in globulins. And there are two broad causes for selective hypoalbuminemia, and they are decreased production and increased loss. Starting with decreased production, there are three things which tend to cause decreased production, and they are inflammation, liver failure, and cachexia or starvation. So to identify hypoalbuminemia due to inflammation, we're really going to look at the CBC for signs of inflammation like neutrophilia, left shift, or toxicity. And also we're going to look at the severity of the hypoalbuminemia. Inflammation tends to cause a mild decrease, and usually the albumin concentration isn't more than 1 unit below its reference interval. To identify liver failure, we're going to look for other things that the liver makes. So on the chemistry panel, we're going to look for hypoglycemia, decreased BUN, and hypocholesterolemia. And we can also look for prolongation of the coagulation times, PT and PTT. To identify cachexia or starvation, we're really going to look at the patient, and on physical exam you'd expect to see a very poor body condition score. So in general it tends to be 1 or 2 out of 9 body condition score, and rarely it could get up to 3. Okay, so now I'm going to move over to increased loss. And the main site where albumin is lost without other proteins, so without globulins, is the glomerulus. And just as a reminder, globulins are very large proteins, and albumin is relatively smaller. So when there's glomerular disease, the glomerular slits, they kind of don't do their job. They open up a little bit, so the holes in the glomerular slits get bigger, and they get big enough for albumin to make it into the ultrafiltrate. So there's lots and lots of albumin that makes it into the ultrafiltrate. However, those slits don't really get big enough to let globulins through. So globulin stays in the blood. So we get lots and lots of loss of albumin, but very little to no loss of globulins. So to identify glomerular disease or renal disease in patients, we look for a urine-specific gravity that is inadequately concentrated. So that will depend on the species, less than 1030 in the dog or less than 1035 in the cat. We also look for increased concentrations in blood of things that the kidneys normally excrete. So if there's renal failure, there's failure to excrete things, so they build up in the blood, and that can be BUN, creatinine, and phosphorus. We're also going to look for protein in the urine. So on our dipstick pad, we can look for lots of proteinuria. And then if it's a chronic renal failure, remember that the kidney produces erythropoietin, which stimulates erythropoiesis. So with chronic renal failure, there's decreased erythropoietin, which can cause a non-regenerative anemia. Now there's also another protein in blood that is a little bit larger than albumin, or about the same size, and that is antithrombin 3. So with glomerular disease and lots of protein loss, there can also be loss of antithrombin 3 in the ultrafiltrate, and then that can lead to a prothrombotic state. And I just realized that I spelled glomerulus wrong. Glomerulus is not not supposed to have the second O. So kudos to those of you who realized I spelled glomerulus wrong before I did.